It's really talking about the early stage of labour and the challenges of that, and trying to give some ideas about some research that we've been involved with, and maybe thinking about how that might translate into different contexts to help colleagues around the world, really, especially, of course, in India. So just an outline of the presentation. We're just going to be looking at the challenges which relate for clinicians around definitions and diagnosis, and for women around decision making and fear. And we'll talk about the implications of getting that wrong, and what interventions have been tried and possible applications of that, both for clinical practice and for research. So obviously we're aware of the physiology of late pregnancy and early labour or latent phase of labour. Lots of things are changing hormonally with the receptors and so on. That takes a long time, and quite often we don't really give acknowledgement to that, I think, in the way that we arrange care. And certainly a lot of women don't understand that it takes time. And sometimes that's why we run into difficulties. Of course, Tina's been referring to the Friedman curves around labour as well, looking at the introduction of what we called phases of labour, which of course we didn't used to talk about it like this at all, because people saw it as one sort of long process. But now we talk about the latent phase and the active phase, and slightly differently for nulliparous women and multiparous women. But actually, it's not so black and white as that, really, and Tina's already alluded to this as well. So looking at what definitions around what is the latent phase of labour, where does it change into the active phase of labour, and different papers define it differently. One paper less than 2 centimetres, 3 less than 3 centimetres, 5 papers that were found defined it around 4 centimetres, one paper less than 5 centimetres, and you can see that the WHO have adopted this as their level. But I know that in America often it's viewed as 6 centimetres. So, you know, there's a huge range, and this is partly why we've run into difficulties. And Tina, I think this was the trial you were alluding to as well earlier, about looking at a very large number of women who were in spontaneous labour, who had normal vaginal deliveries, but they looked back and modelled what the cervical dilatation rates were. And this was particularly interesting because I just want to get this correct for you. The findings of this trial, which looked at an enormous number of women, and I should say that these were women in Nigeria and Uganda, and there may be that is a study that could be replicated in a different region of the world, because it may be different, the findings. But in first-time mothers, they may take up to 7 hours to progress from 4 to 5 centimetres, and over 3 hours to progress from 5 to 6 centimetres. This was the findings of the study, which is really interesting when we're thinking about progress in labour. So WHO definition of the latent phase: it's a period of time characterised by painful uterine contractions and variable changes in the cervix, including some degree of effacement and slower progression of dilatation up to 5 centimetres for first and subsequent labours. So all these things put together present midwives, nurse midwives, obstetricians with diagnostic decisions to make and management decisions about where in labour is this woman and how we're therefore going to carry on with our management and our care. And for women, the problem is deciding when it's the right time to come into hospital and coping with various social pressures from home and from the people around her. So how she's coping with her pain. Sometimes she's actually just looking for reassurance in a period of uncertainty, and that's why she may be contacting care providers rather than necessarily wanting to go into a care facility. And she's also under the influence and advice of others, and often it may be the partner or the family that's panicking about the labour more than the woman herself. It's all these different things that she's also coping with. And so sometimes what happens is she phones up and she wants to come into the care facility, and then she comes in and they say, well, you know, you're not really in labour, and send her home again. And that may be a professional response coping with the busyness of the unit, or, you know, too distracted by other women in labour, whatever it is. And for women, this can be really problematic because they feel they're not being supported. They're being sent away until they're sort of in proper labour, if you like. And it can increase anxiety, and it can be quite disempowering and not giving them a sense of self-efficacy over labour, which is important from, obviously, a psychological point of view. We also need to look at the impact of fear in childbirth, because this is from the woman's point of view, maybe what she's coping with. So there are some large cohort studies that have looked at this, one from Denmark, 2009, where women who expressed fear during pregnancy were more likely to experience dystocia during labour and an increased risk of caesarean section. And another study from Finland, again, women who expressed fear in childbirth had a higher rate of caesarean section, which you can see there from a 2014 study. So it's important, this issue of how women are viewing their labours. And we know about the cascade of intervention. If somebody comes in too early in the latent phase of labour, they're more likely to be assessed as being in labour and having interventions, which may then lead on to electronic fetal monitoring. It may increase the risk of epidural, need for oxytocin, because they're viewed as not making quick enough progress. And when you think back to that study around cervical dilatation rates, maybe we're using oxytocin too early, and that's going to raise the risk of caesarean section. So why does it happen? Mainly because of staff perception of timing. Once you start somebody on a partogram, then they need to make the progress that's on the partogram, if you like. So you've got to make sure that you're starting the use of the partogram at a suitable time, not too early. And if they come in the latent phase, the risk is they start on the partogram too early. So women's perception of time, obviously people get frustrated, they anticipate, because of their understanding of how labour should be, they anticipate more quicker progress, and they get exhausted, and their expectations are not met, if you like. Pressure on services, of course, where the units are busy and so on. This makes, there's a pressure on staff really to speed things along and move people along. And then issues around cost as well. So the latent phase can be regarded as an indicator of those at risk of greater intervention if they're admitted too early. But on the other hand, you've got the pressure of assessing women well, so that you're not sending them home, or you're not gatekeeping and not letting them come to the care facility, and therefore putting them at some risk as well. And it's trying to get the right balance for those two things. These are some of the studies that have been done to look at how to support women coping with the latent phase of labour. Early labour assessment and support at home from Canada, looking at women's perceptions of what the onset of labour should look like from Germany, a clinical pathway for normal labour from Wales, an algorithm for diagnosing active labour in Scotland, and enhanced care and support in early labour from Australia. So there's been lots and lots of studies around the world, but they don't appear to have a huge impact on outcomes. So what else can be done? I want to refer to a couple of studies that have recently been done or are ongoing at Bournemouth University, looking at issues around this, how we can help women cope better with the latent phase so they don't arrive in hospital too early and we start this whole intervention too early, as it were. The first one is a study called the Ball Trial from Dr. Dominic Mylod, and she used a birth ball in the latent phase of labour. So it was a randomised controlled trial with just under 300 women involved, and they were randomised to either watching an infomercial that Dominique developed, which is, this is a little snap from the infomercial around the use of the birth ball at home for coping with very early in the latent phase of labour. And they were given a birth ball and they used it at home during that phase at home. And what was interesting was that they had better scores on their outcomes expectancy, and their self-efficacy scores were higher. So the women felt much better, they felt more confident, and they were more likely to be admitted in active labour. Although interestingly, there was no difference on the pain perception scale that was also carried out. So it looks as if the birth ball could be helpful for women in early labour. And I don't know how that would translate in the Indian context, but it would be an interesting thing to consider because it's low intervention, it's low cost, it's straightforward, it's easy for women to use. There's lots of things about it that the women found appealing, and it gave them a sense of being more in control. That was very clear from the research, and a very helpful thing. The second study that's been carried out by Rebecca Edwards. So Rebecca developed a web sort of like a website with women's voices and their experiences of early labour, and how they coped and what they found helpful, and so on, and what their expectations had been. And then this web-based package was available to one arm of the women in a randomised controlled trial of 150 women. So the experimental arm, the women were able to look at this web-based package, hear from other women about their own experiences, and the control arm just had the normal antenatal care and didn't have access to that web-based package. And the findings from that were that on the early labour experience questionnaire, the women who had had access to this web-based package, hearing other women's voices, scored more highly on emotional well-being and were less distressed. Interestingly, they scored less positively around the role of midwives who were looking after them, which is an interesting finding, and I'm not sure why that was. Maybe they felt more in control of things and more, higher self-efficacy, I suppose. But I don't know why that would have been. But they certainly felt better about it, and I think it was hearing other women and this kind of idea of peer support and understanding better what to expect in the latent phase of labour, that it's not a short thing, and they weren't expecting it to be short, and therefore arriving in hospital too early. So again, this is something that could well be considered, using women's voices to help other women in women-centred care, of course. These are just ideas really around this whole difficult issue around the latent phase. So we're looking at issues of information, so enabling women to make informed decisions using something such as this web-based resource of women's voices. Clear communication from clinicians about the gatekeeping issue for healthcare facilities. How do we communicate with women realistically about that? The issue of accommodation near hospitals. So obviously in some settings that's what happens in rural settings, that there's provision for women to come and be near the hospital and maybe do their early labour stages, latent phase, in a nearby setting where they're not into the whole kind of management of their labour, if you like, but are near enough to access safe care when it's necessary, and how that's managed. The birth ball, as I've indicated to you, has definite potential as a low-cost, useful intervention. Support is important for women, either on telephone or in person. We know that that's what women are often looking for when they contact the unit and they want to speak to a professional, and that can be the way that is handled can make a difference to whether or not they then come into hospital or feel able to stay at home. Trusting relationships, we know increasingly how important that is, continuity of carer, ideally, so that we build trust and women are able to share what's worrying them, and the caregiver understands the woman's perspective and there's different elements that would make up her own care. And then how to change the narrative around what women would expect of labour, and that it can be safe to labour at home. It's not necessarily straight away a risky thing that makes them feel anxious and fearful, but that's a kind of cultural mind shift, isn't it? So thank you very much for your attention, and I'm happy to try and answer any questions, and there are references with the PowerPoint as well. Thank you.